Good morning, everyone. I'm Dr. Piperno-Neumann. I'm a medical oncologist at Institut Curie, Paris, France, and I'm very happy to give this talk about update treatments in metastatic uveal melanoma. Here are my disclosures. So uveal melanoma is a very different disease from the cutaneous melanoma, very rare, 5% of all melanomas, not linked to UV light, with a very different clinical presentation and mostly liver metastases, a very low mutation burden, no BRAF and RAS mutation, but mutually exclusive drive mutations in the GNAQ or 11 genes in more than 90% of the patients. And for all these reasons, the therapeutic option will be very different. Despite local control of the primary tumor in more than 90% of the patients, half of them will develop metastases within 3 years after the primary treatment. And liver is the first site of relapse in more than 90% of the patients, and we have little explanations about that hepatrotropism. Patients do have no symptoms until a few weeks before they die, and the effective treatments for cutaneous melanoma are not adapted to human patients, with rare exceptions, and we will talk about that later. From historical data, as you can see on the right, including two meta-analyses, the first one based on patient enrolled in trials by Dr. Koja, the second one based on real-life patient data by Dr. Rantala, just remind that the median PFS, whatever the systemic treatment, is around 3 months, the median overall survival 1 year, and the 1 year overall survival about 50%. We had no standard of care regarding systemic treatment until tebentafusp, which is the first drug ever approved in metastatic UM patients HLA-A0201 positive, with a demonstrated overall survival benefit, as you can see on the bottom right. What is the place of checkpoint inhibitors in the treatment of metastatic UM? Checkpoint inhibitors are often used in metastatic UM based on evidence on cutaneous melanoma, but with no randomized trial data dedicated to UM patients. The best that we have are small phase 2 single-arm trials. Two have been published recently in 2021, the first one in first line, the second one in second line, combining ipilimumab and nivolumab, and the results are not so different from the monotherapy series, with a response rate up to 18%, but again, median PFS around 3 months and median overall survival around 1 year. I have to stress that the combination of ipilimumab and nivolumab is very toxic in metastatic UM patients, with 40% to 60% from the CheckMate 401 UM cohort of patients, with a definitive stop of treatment in 1/3 of the patient in the US trial, and 2 related deaths in the Spanish one. But in some patients, checkpoint inhibitors are very effective, and this is the story of one of my patients. She's an 80 years old lady. When she developed liver and extra liver mets of uveal melanoma, she had liver surgery at the first relapse, and as the relapse was extra hepatic also, we decided, in the absence of standard of care, to give her a checkpoint inhibitor, pembrolizumab, in monotherapy, and she had an unusual and durable response, partial response, on visceral mets. Blood and tumor samples were extensively analyzed, and mutation in the MBD4 gene was identified in the patient and in the tumor, leading to a CpG mutability that could be the explanation to her response to pembrolizumab. We conducted a retrospective series study of French patients treated with checkpoint inhibitors around about 8 years, and we found that in 1 and 34 sequence tumors, 5 had the mutation in the MBD4 genes, and in that very small number of 5 patients, the response rate to pembrolizumab was 60% versus 4% for MBD4 wild-type patients. So that could be the explanation and predictive of response to checkpoint inhibitors in metastatic patients. We do not have any direct comparison of checkpoint inhibitors and tebentafusp. So there are one indirect comparison conducted by Dr. Pulatz in a propensity score study of tebentafusp treated patients in the 202, from the 202 studies, and Ipi-Nivo treated patients in his GEM 1402 study. This propensity score comparison is of course adjusted to patient data and showed, as you can see on the left, a survival benefit for tebentafusp above Ipi-Nivo with a hazard ratio of 0.43 and a 1-year survival of 73 versus 50%, and on the right, no significant difference in overall survival between the monotherapy and the combination, with a better tolerance for the monotherapy. And this has been confirmed in a very recent population level match adjusted indirect comparison of pooled patients treated with the combined immune checkpoint inhibitors or tebentafusp. So tebentafusp is a bispecific T-cell engager designed to redirect the T cells to GP100 positive melanocytic cells that are expressed at the surface of uveal melanoma in 80% and present of cells and presented by HLA-A2. In the 202 randomized phase 3 trials, first-line patients were randomized 2-to-1 between tebentafusp with the intra-escalation dosing and investigator choice of monotherapy with DTIC, ipilimumab, or pembrolizumab. The primary endpoint of the study is overall survival, and in the first analysis, after a follow-up of 14 months, tebentafusp showed a significant benefit in overall survival, as you can see here, with a hazard ratio of 0.51, a median overall survival of 22 months versus 60 months in the investigator choice. And based on these first results, the drug was approved in 2022 by FDA and EMA. Very recently, we published an update of the study after a minimum of 3 years of follow-up of the patients. And with this 3-year update, the study continues to show a significant benefit in overall survival, with a median overall survival unchanged, and a 3-year overall survival rate of 27% in the tebentafusp arm and 18% in the IC arm. As you can see, the response rate is modest, 11%, the median PFS around 3 months, but there is a very important disease control rate, around 50%, with durable tumor reduction that behave like a PR. And you can see here the green lines on the spider plot with tebentafusp compared with investigator choice. As in the initial analysis, the overall survival benefit is also seen in progressive patients treated with tebentafusp and compared with progressive patients in the investigator choice, with a median overall survival in PD patient on tebentafusp of 15%. So that is to stress that survival benefit is seen in all RECIST categories patients, and probably that RECIST evaluation underestimates the overall survival, and stress the need for biomarkers predictive of tebentafusp benefit. In the 202 study, there were an exploratory analysis of ctDNA across the study. All the patients in the TB arm were explored for ctDNA, which was detected by NGS based on the 6 major specific mutation from detected, so in 60% of the patient at baseline. As you can see here, 88% of the patient of this population of patients showed any reduction of ctDNA by week 9. 37% of them cleared totally ctDNA by week 9. And this was seen again across all RECIST categories of patients. The ctDNA level at baseline was, of course, correlated with tumor burden, but was also correlated at week 9 with the best overall survival benefit in the whole population, in patients who cleared ctDNA, but also with patients showing a more than 50% reduction of ctDNA by week 9. And again, this benefit was seen in patients in progressive disease and was able to split in patients with progressive disease on tebentafusp, the patient we will have the best overall survival benefit on the tebentafusp. So early ctDNA reduction or clearance by week 9 is associated with the best overall survival improvement across all RECIST categories of patients. We have a lot of questions to address regarding the monitoring of tebentafusp treatment. First, what is the optimal duration of treatment? We can see late responses in patients showing an initial progressive disease or showing months of stable disease by RECIST. So the message is not to stop too early the drug. Of course, patients with an early disease progression and a high tumor burden are not good candidates for tebentafusp. Toxicity is not an issue. To stop the treatment, with AEs of skin toxicity and CRS very manageable, and a very low rate of discontinuation with tebentafusp, and absence of long-term dosing AEs. more than one-third of the patients who were treated beyond progression in the randomized trial showed a clinical benefit after initial PD. So we have also to study what is the duration of that clinical benefit on TB, after TB, and to describe the response to learn about the treatment. So what do we have to do? Continue the treatment indefinitely, or try to use the ctDNA monitoring that could eventually permit to discontinue the treatment in selected patients? But are we ready for ctDNA in routine? Do we have alternative imaging criteria as the tumor growth rate? Do we have to propose a discontinuation trial, or to share the decision with our patients? And what are the mechanisms of resistance with the drug? So the take-home messages is that tebentafusp is the first bispecific to demonstrate a survival benefit in a solid cancer, and is now the standard first-line systemic treatment in metastatic patients positive for HLA-A0201. RECIST responses do not predict the survival benefit with tebentafusp, and ctDNA reduction, early ctDNA reduction, may be a surrogate biomarker to predict the clinical benefit to the drug. That has to be demonstrated prospectively. Next steps, combination trials in the metastatic setting, and the EORTC adjuvant trial in patients with high risk of metastasis will begin soon. Do not forget that half of our patients are HLA-A0201 negative, and that we need for this patient new trials, new drugs, combining systemic and liver-directed therapy. Thank you for your attention.